Okay, I think we'll get going. I know we still have a number of people still to join, but I think in the interest of time and keeping to time, we'll crack on if that's okay. So welcome everyone to the midpoint of the collaborative. This is our first sharing and learning event. We are 3 months into the collaborative, and we've had a great day so far. So we've had 3 keynote presentations, which has both been inspiring and also created its own kind of headache, because we've not been able to turn off, or at least I haven't. I've been thinking all morning and reflecting on stuff that I now need to do, which is always a good sign, I think. So just a thank you to Olivia, Elaine and Sankara, and also to Andy Molyneux for their presentations this morning, which have linked very nicely with the collaborative, but also given a different perspective on some of the work that they've been doing that we could bring into the collaborative in the second half. The main event today is going to be sharing of the poster presentations. We've got 9 presentations that have been divided into 3 poster rooms. If you stay on this link, you will be dropped into the poster rooms at random. So we've got the presenters all teed up, but the rest of the delegates will be split randomly between the 3 rooms so that we get approximately equal numbers in each group. And there'll be 3 presentations from teams on the work that they've done so far. If you haven't submitted a poster, please don't worry, that's okay. Just join anyway, contribute, reflect, think how the posters can influence the work that you're doing and can take forward. Following that, we'll have a short break, and then we've got a final session which will provide some feedback from the 3 poster sessions. We're going to hear from the evaluation team about some of the work that they're doing behind the scenes to support the programme, and then we've got Claire's going to present some work about the next steps and some exciting new pieces that we're going to bring to the collaborative. So without further ado, oh yes, one final thing, I'll get into trouble if I don't say it. One final thing is just to remind everyone that after our events, we are asking for feedback. If you complete the feedback, you are able to get a certificate of attendance, which is really important for your revalidation if you're a healthcare professional, and the feedback is really important for us. So we've amended today's sharing and learning event based on the feedback provided by the initial launch event. So we'd really value your opinion on whether it's been good, bad, indifferent, and what we can do differently next time. So I'm going to introduce our key faculty from the Modern Ward Rounds document. So John Dean, Nicola Ashby and Eddie Kinsella, representing the RCP, RCN and the Patient Care Network respectively. And just start this session by asking a few reflections, if I may. So I'm going to ask a question of each of the 3 members, but actually get everyone's reflection, if that makes sense. So Eddie, if you don't mind, I'd like to start with you. We've mainly because patient involvement and patient engagement has been such a key feature of the collaborative so far. And I wondered what your reflections on that has been and what your thoughts going forward on it could be.
Well, thank you, Andrew. I've been impressed so far, first of all, with the enthusiasm, the genuine commitment to try and make things better for patients. I think one of the things that strikes me, not just with today's presentation, but generally, and it applies to me as much as to anybody else, is the degree to which we make assumptions about the way things are for patients. So it's important in any initiative, in any attempt to improve quality, to be clear about the way in which you want to engage with patients, because obviously there are different types of quality improvement projects and there are different types of patients. Obviously every patient is different. So you need some clarity from the outset. What are we looking for? Are we looking for somebody with a particular lived experience in a particular specialty, a particular disease, whether that's diabetes or COPD, whatever it might be? Are we looking for somebody with a generic background, a wider perspective, or are we looking for a mixture of the two? I mean, Marion's comment earlier on, I think was absolutely spot on, because Marion is obviously somebody with a long-term condition. So you're not talking about somebody with an episode in their life, but you're talking about somebody, this is their life. So you need to be clear about how you want to involve patients, and you also need to be clear about the extent, the stage at which you want to engage with them. I mean, I'm sure everybody is, clear about the so-called ladder of engagement. Is it just informing patients? Is it actually consulting with patients, or is it, from our point of view, the holy grail for the patient care network? Is it true co-production, where you actually sit down at the very beginning? And that's certainly something we would always advocate from the very beginning of any attempt to improve things, to actually engage with patients. So it's very much a partnership. Now, to add to that, you also need to have regard to the fact that, as I said earlier, obviously we're all different. We all bring our own personal baggage, our own particular social values, whatever it might be. You need to think about how, what type of audience, what are the sort of impediments to effective communication and engagement, whether that's, something that's profound, a disability, hearing impairment or vision impairment, whatever. So all those types of things need to be taken into account. The most important thing I can say is that because we all make assumptions, patients can actually be a terrific guide through the maze. They will be knowledge brokers, in effect. They'll give you that different perspective. Because with my background, perhaps not everybody knows, I was very much heavily involved in the NHS in my career. But even I made assumptions. And when you're on the other side of the fence, it's actually very different. So patients can actually help you through that. I do not believe anybody comes to work in the NHS to do a bad job. Everybody's obviously committed. They want to improve, give their best for patients. And that's certainly been, epitomised by the devotion and commitment during the pandemic. But notwithstanding that, people work in pressurised environments. And so the dilemma, as I see it, is that there's a danger things become mechanistic and task focused. We've got to take the bloods, we've got to do the pressure sores, etc. So the totality of the patient experience can inadvertently be lost. So long-winded answer, but be clear about what it is you want to do at the outset. Be clear how you're going to engage with patients. Be clear about what type of patients you want to involve in, and also be realistic. Be honest with people about what the constraints are. So long-winded answer, but that's my 2 pennies worth, I think.
Eddie, that's fantastic and very comprehensive. So thank you very much. We have a number of patient engagement / involvement, because there's slight overlap in some of the posters this afternoon. Obviously, you won't be able to see all the posters, but you'll see there should be a theme of that in all of the rooms. I think it just to encourage those who are doing it to continue. That's great. Those who are, there can be a bit of a culture of fear about, gosh, it's quite a bold step to involve patients, but actually I think we'll see from the posters today that actually just making that step, it opens up a huge door and a huge opportunity for the improvement space. So thank you very much, Eddie. I'm just going to amend things in terms of time. I'm going to come to Nikki next, if I may. We've heard a lot today and in the clinical learning events about team working and the importance of team working. I wondered about your reflections on the benefit of that within the collaborative and using the collaborative to improve team working, particularly as we come into winter and the challenges that we face.
I think one of the things that I've learned throughout the collaborative and also throughout the development of the document initially was the vital importance of team working, and that team was based around our patient responses and our patient engagement and patient work as we developed that. This has been a huge piece of work really that started some time ago, and it's really good as we've seen this collaborative to develop to see it not only from the different disciplines but also the different areas across clinical practices, because it's really important that everybody has that goal in mind and works as a team towards that goal, and also takes into account each person's individual perspective and the communication of that perspective as they develop these quality improvement programs and projects as they develop forward. I think this is an ever reflective process and an evaluative process as we move forward, and John and I have spoken a lot, and with yourself, Andrew, about the what next. So, and about how this evolves and how this collaboration evolves and what comes next around education, around further developments. And I think for me, one of the big areas of learning around this collaborative is when these projects and when improvements are in place, that isn't the end of the story. And that isn't the end of the journey, and that's demonstrated really throughout this course, is that there are so many different ways of looking at improvement and quality improvement and implementation. To keep talking and keep taking into account the different perspectives and views about that is vitally important to improving patient care and improving the delivery of that, and I think that's an essential component. So this partnership for me has been fantastic, and as we see this coming to fruition and this course developing, there is a significant amount of interest from other nations across the devolved nations, and from an RCN's perspective, that's an excellent opportunity for us to be able to share learning, not only hospital to hospital, but also and discipline to discipline, but country to country, and also internationally. So I think this is a fantastic opportunity.
Excellent. Thank you very much, Nikki. That's fantastic. And just to reiterate, I mean, we do not see this collaborative as a, if you like, a 6-month project that on the 15th of December stops. This is just the start. And we heard beautifully from Elaine and Sankara this morning about how their shared decision-making council started on their ward, and now, several years later, it's spread across 10, 11, 12 wards, and that's exactly the kind of sort of movement we want to start generating through the collaborative. Thank you, Nikki. Oh, and as an aside, if it does go international and you need a travelling companion, I'm very happy to go overseas and promote the work. So just we'll make note of that. John, I'm going to come to you lastly before we go into the poster session. We've talked a little bit about what next. Nikki's talked a little bit about the 4 nations. We had a conversation this morning which is fascinating about the art of wardcraft. Please do share your views on this with us.
Yeah, thank you very much, Andrew. I think we are seeing, and I hope it's not just because we're really close to the centre of this. I think we are seeing a bit of a movement change here, a bit of a refocusing on what many of us who are later in our professional practice really got rewards from earlier in our professional practice, which was working as teams on wards, knowing our patients and the person that is the patient, and really seeing that multidisciplinary working, the decision making, the ward round as a core component of that, as a really invigorating part of practice. And I think what sadly happened over many years is that it's become a bit of a chore for people. It's been seen as just being medical and not the whole team. Sometimes, as we've heard, the patient and person perspective has been lost from that. But what I'm sensing, and what I think a number of us are sensing, is a real reinvigoration of fact that this is core hospital practice. And if we get it right, it's really rewarding. Our patients get better outcomes, and we actually enjoy our work more as well. So what I'm seeing, and in a number of discussions I'm in, is around not just about what the processes are on wards, but actually what are the skills that we need as individual and collective members of the team for ward work to work well. Not only for ward rounds, but many of the other processes there. And within my own organisation, we've started to frame this as ward craft. So what is the craft that we develop and continue to adapt so that we work well on wards in all the multiple aspects of things we do, not just decision making, but actually, follow-up tasks, how we identify risks, how we hand over, how everything just becomes coordinated, how we support each other, how we document, etc., etc. So I think this concept of reinvigorating the craft of working together as teams on wards with patients has some growing momentum, and this collaborative is certainly helping that.
Brilliant, John. That's absolutely fantastic, and I'm really looking forward to being part of those conversations moving forward. We've had Kate's already made a comment, but I see lots of nodding heads around the virtual room. I think that resonates with all of us. So three of you, thank you very much, not only for your thoughts just now, but for your ongoing support, both as individuals and as representatives of the colleges and professional networks. It's really appreciated, and it's hugely valuable for us within the collaborative, and very much appreciated.